Well, good afternoon, everybody. My name is Christoph Stremikis. I'm the Director of the Market Analysis and Insight Program at the California Healthcare Foundation. CHCF is an independent, nonprofit philanthropy dedicated to meaningful, measurable improvement in the healthcare delivery system here in California. Today is an exciting day as we release another study from our Regional Market Report series. Caroline, if you can pull up the first slide, our audience will see here that our regional market reports are in-depth studies of 7 diverse areas that reflect the range of socioeconomic, care delivery, and financing conditions that we have here in California. You can find this report, which is focused on the San Diego area, and all the collateral from this webinar on our website at chcf.org. We have one more regional market report on the San Francisco Bay Area to release, and we'll be conducting a webinar sometime in early May. On the next slide, you'll see that we're fortunate today to have the lead author of the San Diego report, Caroline Davis, here to briefly highlight her findings. We're also joined by the impressive group of local healthcare leaders that you see on your screen. Each is here to talk about the unique challenges and opportunities that they're seeing in the San Diego area. 2 very brief housekeeping items before I turn things over to Caroline. First, please do take advantage of our panel's expertise by entering your questions into the Q&A box at any time during the next hour. My colleague Ann and I will monitor these questions and squeeze in just as many as we can after everyone has had a chance to speak. And second, please do take a minute when the webinar concludes to fill out the evaluation that'll pop up on your screen. It'll just take a minute, and I can tell you your feedback is really valued and helps us with future programming. So with that, let's get started. It's my great pleasure to turn things over to Caroline Davis. Caroline is president of Davis Health Strategies and lead author of the Regional Market Report on the San Diego area. Caroline, can you unmute yourself and turn your camera on and get things kicked off for us?
Thanks. So good afternoon, everybody. Really happy to be here to share the results or the findings from our report on San Diego, which we entitled Competing, Collaborating, and Forging Ahead with Population Health. Just a few words about the approach for the regional market reports. These reports are really intended to tell the story of healthcare in one of 7 regions in the state and really try to document the developments over the last 5 years. We did that through a combination of qualitative and quantitative research. For San Diego, that included interviews with 23 regional leaders representing the plans, the providers, county government, community leaders, as well as advocates. We coupled that with quantitative analysis of data from surveys and the census and other sources, as well as news articles, industry reports, journal articles, and other sources specific to San Diego. Just a word about the context for this project. Of course, we've been in a pandemic for the last year plus now, but this project was launched before the pandemic began. So while we document some of the early experience in San Diego with the pandemic, we did not do a deep dive, and the pandemic is not a focus of this report. The interviews for the project were conducted between January and September 2020, with many of them happening over the summer, so right as California was emerging from the first surge from the pandemic. I also want to acknowledge that this is really a team effort. I want to particularly call out my co-author, Katrina Connolly, for her help with this report, as well as the contributions from the rest of the Blue Sky Consulting Group team. So just a little bit of background about San Diego to kick things off. It's home to over 3 million people. For those of you not familiar with the geography of California, San Diego is located on the southern border with Mexico, so down in the southwest corner of the state. And the population is really clustered around along the 50-mile coastline. The inland areas are rural and less populated desert. Compared to California overall, the population is faster growing. And then, as you can see in the pie charts here, which compare race and ethnicity for San Diego to California as a whole, the population in San Diego is more white and less Latinx. You can see in the pie chart on the left, in San Diego, the white population makes up about 45% of the total, compared to 36, almost 37% in California as a whole. The Latinx population is about 30% in San Diego, 34% in San Diego, I'm sorry, compared to 39% in California as a whole. And the African American population makes up about 4% of the population in San Diego compared to 5.6% in California overall. San Diegans are more likely to have higher incomes than Californians as a whole, and they're also more likely to have high school diploma or a college degree. Looking at health insurance coverage in the region, the number of uninsured San Diegans has decreased since 2015. It's now at about 8%, as you can see in the pie chart on the left. More than 50% of San Diegans have private coverage, and Medi-Cal covers almost 25% of the population. About 22% of San Diegans have Medi-Cal coverage. So compared to Californians, San Diego County residents have more private coverage, 53, almost 54% in San Diego compared to 47.7% in California as a whole. And they have less Medi-Cal coverage, 22% in San Diego compared to 28, almost 29% in California. So we took a deep dive and looked at the Medi-Cal model in the region, which is the geographic managed care model. In the GMC model for Medi-Cal, enrollees in San Diego have a choice between a number of private healthcare plans for their coverage. And that model has been growing in San Diego over the last 5 years. The Department of Healthcare Services added 2 plans, Aetna and United Healthcare, in 2016. Blue Shield of California also entered the Medi-Cal market with the acquisition of Care First Health Plan in 2015. So a total of 7 health plans, as you can see in the table on the right-hand side of the slide. Those 7 plans serve about 730,000 Medi-Cal members. Community Health Group is the largest of those plans, and Molina Healthcare is the second largest in terms of enrollment. We heard in our interviews about how challenging it is for providers in the region to work with multiple health plans in terms of their focuses and initiatives. And I think it's important to note to that end that the Department of Healthcare Services intends to recontract with the San Diego GMC health plans beginning in 2021. The RFP is scheduled to be released later this year. When that process is completed, the expectation is that DHCS will reduce the total number of plans serving the Medi-Cal population in San Diego. Turning to the hospital sector, which has been long consolidated, there are 4 major systems that account for almost 3/4 of the acute inpatient discharges in San Diego. Sharp and Scripps account for about half of the discharges. UCSD Health and Kaiser are the other 2, with UCSD Health accounting for 11% and Kaiser for 9% of inpatient discharges. The market overall, the hospital sector has been relatively stable over the last several years. There have been no mergers or acquisitions. And Kaiser and UCSD Health both have opened new facilities in the last 5 years, with Kaiser also breaking ground last year in 2020 on its 3rd hospital, which will be located in the northern part of the county near Escondido in the city of San Marcos. As you can see from the table, the hospital operating margins in the region overall remain strong. The operating margin for San Diego's, the average rate for San Diego hospitals is over 10%, which is more than double the statewide rate. Even so, we heard in our interviews about the financial challenges for some of the smaller independent hospitals in the region, including the district hospitals. So not all rosy for every hospital in the county. There are more physicians in San Diego County per 100,000 residents than the statewide average, as you can see in the table here on the right-hand side of the slide. In San Diego, there are 211 physicians per 100,000 residents, compared to a rate in California of 191 physicians per 100,000 population. Access to certain specialists, even with that, access to certain specialists remains a challenge, and we heard about that in our interviews. The medical groups in the region are really focused on growth as the health systems are embracing and expanding population health strategies. For UCSD Health and Scripps, that has included building their regional footprints and expanding their provider networks as a part of pursuing more risk-based contracts and being competitive for those kinds of contracts in the region. In terms of the private practice model, that model, similar to other regions of California, continues to erode. Partly that's as older physicians who are nearing retirement seek exit strategies and join the medical groups and the FQHCs as employees. And of course, younger physicians coming right out of medical school also prefer employment rather than establishing their own practices. The federally qualified healthcare centers in San Diego are really thriving. There are 14 FQHCs with more than 100 sites located across the county. They have seen a pretty significant growth in number of patients and in encounters per capita or visits per capita provided to patients in San Diego. Between 2014 and 2018, encounters per capita increased by 40%, largely due to the expansion of the Medi-Cal eligibility criteria in 2014 as part of the Affordable Care Act expansions for Medicaid. FQHCs in the region are expanding their services. They're growing in terms of their patients, but they're also expanding services, in particular to address mental health and substance use disorder needs for their patients. They're also starting to think about how to retain their patients as they age into the Medicare program. And 2 FQHCs are Program of All-Inclusive Care for the Elderly, or PACE providers. The FQHCs in San Diego have a long-standing focus on addressing workforce challenges. Some of the FQHCs run their own residency programs, for example, and others partner with health systems in the region or medical schools to run residency and training programs. And then I think of note, the local clinic consortium in San Diego contracts with health plans on behalf of a subset of their consortium members of their clinics. And they have about 250,000 managed care enrollees in San Diego and neighboring Riverside counties through their clinically integrated network. We looked at access to behavioral health care in the region and found that it's viewed as being challenging. Access is really viewed as a critical need. Psychiatrists in the region were particularly noted as being in short supply, both for the general population, but specifically for the Medi-Cal population. And those access challenges are with both the inpatient and outpatient behavioral health services in the region. To help address some of these challenges, the county, San Diego County, has developed a hub and network initiative with the goal of restructuring the delivery system for behavioral health across the county. And the focus of this initiative is to connect patients following hospital discharge to community-based care and care coordination with the goal of trying to reduce hospital readmissions for the population. They envision that up to 5 hubs would be created. The first one is what's known as the Central Regional Behavioral Health Hub in the Hillcrest neighborhood in San Diego. It's sometimes referred to as the 3rd Avenue Hub. And they're doing that in partnership with UCSD Health as part of UCSD's rebuild of their Hillcrest hospital to meet the 2030 seismic requirements for the state. We also looked at health information exchange in the region, which is really considered a pioneer or a leader in the state in terms of health information exchange. There's a regional HIE, which is known as San Diego Health Connect. There's a community information exchange, CIE San Diego. And then the county also has a information hub, Connect Well SD. To build or develop the regional HIE, San Diego is one of only 17 communities nationally that received federal grant dollars through the Beacon Community Program back in 2010. And the HIE, in our interviews, we really heard a lot about the strong support the local stakeholders have for the HIE. Many of the health stakeholders and big health systems are on the board of the HIE. They provide data to the HIE and retrieve it on behalf of their patients. Even so, we did hear about some issues around functionality with the HIE, and it's lacking some things that providers would find really useful or helpful, and so it's somewhat underused. Kind of in parallel to the HIE development in the region, the major health systems have also been coalescing around a couple of electronic health record systems, Epic and Cerner, and so it seems that the HIE is somewhat of a crossroads, needing to demonstrate its value to stakeholders as those major health systems roll out their own proprietary EHRs across their systems. And finally, just want to touch on the emerging experience that we heard about with COVID-19. In terms of some of the data we looked at between February and August 2020, unemployment in San Diego the unemployment rate did triple, growing almost to 10% between those months, February to August, but it was still lower than the statewide rate of 11.4%. And then, as you can also see on the table here, Medi-Cal enrollment was growing faster than California overall. In terms of early experience with the pandemic, San Diego's location on the border with Mexico, of course, presented some challenges as patients came across the border seeking care, and that really put a tax the healthcare system, both in San Diego and neighboring Imperial County to the east. In terms of, collaboration, that was really seen as critical by many providers to help manage care in the community, in the region. And collaboration is one of the kind of key defining features of San Diego in terms of how the provider community works together, and that was seen really as a strength. Thinking about, where the pandemic hit particularly hard, that was southern San Diego County and the communities in that part of the state. That part of the county, I'm sorry. Those communities tend to be lower income and have more, for example, essential workers who were not able to shelter in place. And then the pivot to telehealth was really seen as a bright spot in San Diego, as well as other parts of the state and nationally. So finally, all of the regional market reports end with a list of issues to track, which is really our attempt to peer into our crystal balls and think about what might be coming and what issues to watch for in the future. I'm not going to run through these in the interest of time. I'm going to hand things back over to Christoph. But before I do, I just want to express my appreciation to our panelists today, who I know are going to share a lot about their good work and the interesting work that's going on in the region. So Christoph?
Thank you so much, Caroline. That was perfect. I'm really excited to turn things over now to the panel of local healthcare leaders for their perspective on some of the challenges and opportunities that they're seeing in the community. Just as a quick reminder, each panelist will provide about 4 or 5 minutes of remarks on any findings that were particularly surprising, anything that really resonated, or anything else they'd like to highlight. And as a reminder to our audience, please do feel free to type in any questions for our panelists into the Q&A box, and we'll get to just as many as we can in a couple minutes here. But at this time, I'd like to turn things over to our first panelist, Parag Agnihotri, Chief Medical Officer at UC San Diego Health. Parag, I see you've got your camera on. Can you unmute yourself and let us know how do things look in San Diego from your perspective?
Thank you, Christoph. And first of all, thank you for having me on this panel. Just to first my reaction to the report, I think just the title of, Forging Ahead with Population Health, I really love the title. It's very nice and really, when you look at San Diego region, I think there has been a lot of collaborative work that's been going on. It's around cardiovascular disease, around accountable communities for health, what you just mentioned around behavioral health, and etc. So, I think that Caroline and Katrina have done, an excellent job in really capturing the essence of the current San Diego healthcare, in the region. So that's very good, and thank you for doing that. I have 3 observations, related to report, which I would like to share. The first one is around the growth of the network. So when you look at, even when you look at what's happening on the national trend, where and how physicians practice and the support they need continues to be a key change driver right now. The second is in San Diego market, there is a 20% growth expected in the outpatient space or ambulatory space, mainly driven by the burden of chronic diseases. So even for us, when we look at this, as UC San Diego Health, when we look at these 2 trends, we have to be innovative and we have to make sure that we have a presence in the community, and hence we are having more community care locations at different sites throughout the county. We're also under the umbrella of clinically integrated network, partnering with local physicians and local practices, on providing a chassis of digital health and really using a population health management strategy to really bring affordable healthcare to a larger San Diego population. My next point, the second point, is around the value proposition which San Diego region brings to the payers and employers. So if you look at, the Integrated Healthcare Association's, IHA's Atlas data, which compares cost and quality across the state, you can see that, San Diego region has remarkable performance, a solid performance on commercial and Medicare Advantage plans. So, we provide great value healthcare. We can't say the same about housing, but, that's a totally different topic. But at least for healthcare, the San Diego is great, But as we can, look at, the downward pressures we face on the capitations or the payments being made to the provider organizations or the shift towards financial risk taking, we have to, strike a balance. We have to strike a balance where we need the necessary payments to really keep our population healthy in the region. If you look at the Medicare side of business, the CMS has a lot of new models. And it's possible that we may have new entrants coming into this, into the region, partnering with some of the community practices through the direct contracting model with CMS and bypassing the regular health plans. So, but we'll see what happens. This could be a disruption, but irrespective of that, we do think that the movement towards value-based care will continue in the region. And which model succeeds, which model fails, we'll have to see. And that's for the next report, which Caroline and Blue Sky Group may have to write. The third point is around the aging population in San Diego. If you look at our demographics, 75 plus is the fastest growing segment of our San Diego region. And with that, there is a side of care shift happening. More people want to receive care in their homes. The same way all of us wanted during pandemic, more services to be, received or delivered at our homes, And if you look at the nursing home, even though they comprise 1% of the population, 34% of the COVID deaths, unfortunately, were among nursing home residents. So we have to find ways to address the aging population, reduce the long-term institutional stay of our members in the community. We have to find ways to provide home-based services, whether it be home dialysis, home infusions, or connecting patients with telehealth. Even President Biden's latest infrastructure plan, is addressing this important issue. So I think, in the years to come, I hope and I think the region will continue to be known for its top-notch healthcare system being delivered through the hospital system. But also it will continue to be recognized for leading the way to provide care in our communities in an equitable manner, but also delivering care in the homes where our patients and our members need it the most. So those are my three things, Christoph, and I'll pass it on to our other panelists. Thank you.
Thanks so much, Parag. That was perfect. A lot of really interesting topics that you touched on there that I hope we're able to get into more in the Q&A. But next, let's keep moving here in the interest of time. It's my pleasure to introduce now Luke Bergman. Luke is Behavioral Health Services Director for San Diego County. Luke, I see you have your camera on and your camera unmuted. How do things look from your perspective?
Things look rife with challenges, but also replete with opportunity in the world of behavioral health, and I think healthcare generally in San Diego County. But, we're having something of a political moment here, which I can sort of speak to with sort of a native perspective as a component of local government. The newly elected board includes more Democrats than previously, than maybe ever, certainly than in many, many decades. And so there's a sense of great activism politically, kind of in the local scene. And along with that, certain commitments that I think will accelerate the work that we all sort of have interests in doing right now. For example, a really pronounced commitment to foreground considerations of equity in ways that they haven't traditionally been foregrounded in San Diego County, and a commitment to do work across health and human services in ways that are increasingly integrated. So an eagerness to think about and to make investments in how we can think about the relationship between healthcare and housing, for example, in more progressive and in more instrumental ways. There is also, I would say, a really pronounced commitment kind of local political landscape to do more with behavioral health, and I think that that commitment has contours that I think will leave us in a considerably better place than we've been locally in quite some time, and that I think we really have an opportunity, in fact, to be if not a state, or if not just a state, I would say a national leader in some of this work. Before coming into San Diego County to work, I was working in New York City for the previous decade. I've been here for a couple of years at this point. And in New York, I worked at the health department at NYC, Department of Health and Mental Hygiene, and then in the public hospital system, they're overseeing a pretty massive behavioral health service across the New York City public hospital system. And so I've come into this position with a real commitment to do integrative work and to do work that is informed by a public health and population health focus. And that is sort of very resonant with the politics of the moment. And so I think there are great opportunities to push a lot of that forward, maybe in an accelerated way. A lot of that hinges ultimately on what we can do to best integrate work on behavioral health with work on broader physical healthcare. And I would say, if you sort of, talk to folks across, points of interested vantage across the county, you will get unanimous, I think, declarations of nominal commitment to integration. The challenge is that so much of that work is, of course, driven by payment structure. And we work in the context of geographic managed care, as was noted by Carolyn. That presents certain challenges. There are in the sort of particular and somewhat peculiar sharing of payment responsibility in California and in San Diego County in particular, also some somewhat perverse incentives that work against our efforts to create better integrated care. I'm coming from New York. I lived through a full carve-in of the Medicaid program there while I was at the health department, and then as I moved into the public hospital system, behavioral health was fully carved out in Medicaid, and there was a real sort of institutional, cultural separation of the work that was, of course, heavily reinforced in practice by all of the peculiar regulations that attend to behavioral health services. I have experienced that transformation in real time, and so have great confidence that we can actually get to a place through changes in payment, ultimately, where we will be working with incentives that payments are sort of meant to be compelling instead of against them. But we're not in that moment quite yet. I'm anticipating that at some point we will be. That's the thing I think we need to keep our eyes out for, and that's a conversation, obviously, that we need to continue to participate in. So the questions for the current moment are: what can we do now to best situate ourselves for a world in which payment will drive work differently? And I think our focuses there need to be around, with kind of noting the emphasis on HIE and other efforts locally, we need to do way more on data infrastructure building. And that's across healthcare, but also between entities like healthcare and law enforcement. And we need to do a lot more development of integrated practice. That's a lot of why we have an emphasis on this kind of hub and network model that entails a kind of principled integration of behavioral healthcare into broader physical healthcare work. And I think we need to take the moment and opportunities that come with things like the American Rescue Plan and make capital investments right now that we sort of have a singular kind of generational opportunity to make that will, over years into the future, really accelerate our efforts to do work in more integrated ways. Again, in anticipation at some point of payment structures that will really facilitate us getting where we want to be. I'll stop there. Thank you.
Luke, that was super interesting. Thank you for that perspective, and really looking forward to digging in on some of those issues in the Q&A. But let's keep going here. Next up is Anil Kaswany. Anil is Chief Medical Officer at Scripps Health. Anil, I see you got your camera on, yourself unmuted. Take things away.
Wonderful. Good afternoon, everybody. It's wonderful to speak to you all, although I wish it could be in person rather than virtually. You know, it's as I mentioned, my name is Anil Kaswany. I'm the Chief Medical Officer of Ambulatory Care and Population Health at Scripps, and good to see many familiar names and friends in the list of participants. So first, I'd like to say it's kind of nice to talk about something other than COVID. It seems like the whole year has been nothing but COVID, and it's good to talk again about things that as we look towards the future. And I'll just make a few brief comments, and hopefully there'll be questions at the end. So really, I'd say what a year. This has been an unprecedented year. And while the pandemic was truly a challenge, I think one thing that really isn't reflected in the report is how this challenge or how this pandemic brought all these health systems together. And it was very, very heartwarming to see in the midst of the pandemic how we were all working and collaborating for a single cause, which is to help San Diego get through something that we've never seen before. It was looking at how we kind of work together to fight a virus, and not just fight the virus, but how do we garner resources? How did we share learnings? How did we make sure that we can manage scarce resources like fluids or like hospital beds? And what it did is really built new relationships that evolved that even since this report was written. We got through it together, and I think, you know, whether it was testing, vaccines, or management of these scarce resources, the relationship we have is going to be serve as a great support for the future in San Diego. In terms of the pandemic, I think the three areas I think that really accelerated our growth are really public health, population health, and digital health. If you look at how we all work together in public health, which is really not reflected in the report because it kind of predated a lot of this work, how we all work together with county, regional, state, and national agencies is amazing. I mean, we were on calls regularly. We worked regularly to make sure that we could make sure San Diego had received the resources it needed. In terms of population health, we were really forced in the new care delivery model. We didn't have the availability of bricks and mortars on the ambulatory side. We had to manage how we were going to take care of patients, regardless of whether they were fee-for-service or managed care. How were we going to make sure that we could prevent hospital admissions? How could we make sure we could provide infusions at home? Things like you know, some of the treatment regimens for COVID. How could we do that with a home infusion rather than even bring them into the ambulatory setting? And then digital health, we took a leapfrog forward. This was really healthcare's catch-up moment, and just absolutely catapulted forward with digital medicine. And again, I think with the relationship and the partnership with health plans, as well as some changes on the national level, payer issues kind of were put to the side, and we were able to really motivate and gear our physicians and providers into a new digital care delivery model. So as the pandemic subsides and kind of ends up in our rearview mirror, all the work we've done is going to continue to improve our healthcare systems. In terms of the report, there's about two things I'd call your attention to that I think will be really important to consider. One is there's a statement in the report that talks about San Diego residents and says, as a whole, we have more education, higher incomes, lower poverty, and lower unemployment rates. And that sounds really good, but the caveat to that is 1 in 4 residents in the region live in a household earning less than 200% of federal poverty level. And I think that's an important statement to think about, because as the pandemic hit all of us, it's going to hit some of us harder than others. And we have to think about how are we going to get vaccines out to those folks who are in a different socioeconomic status or that have different housing arrangements. How do we make sure the folks that are most vulnerable and may have been most economically challenged by the pandemic, how do we make sure that their health care is appropriate for what they need in the future? And the other area in the report I think that's really worth a call out is a comment, and it's about Scripps Health and our work with Qualcomm, but also the work with narrow network HMOs. And I think one of the things we have to do as a region is continue to look at affordability as an access metric. Affordability is accessibility. If we need to look at models of care that allow the total cost of care to go down, because if we do that, it's a great way to encourage employers to enter our region and see a thriving San Diego. So while it's not a surprise to see in the report, I think it deserves a special call out that we all need to work together to provide better care for those who are most vulnerable, but also provide a better service to employers by reducing premiums and total cost of care. So with that, I hope you do take some time to put some questions in the chat box, and look forward to hearing from you all.
Thank you so much, Anil. That's really a great perspective and nuance on some of these issues, and I hope we can dig into them a little bit more in just a second here. But certainly excited to hear from Vernon Todd and hear the perspective from the clinics. Vernon is Chief Strategy Officer at San Ysidro Health. Vernon, I see you have your camera on. Can you unmute yourself and take things away for us?
Thank you so much, CHCF, Christoph, and the team for inviting me here to talk about the great work Caroline and her colleagues did on this regional study. And while I echo many of the comments my colleagues have shared about the importance of behavioral health and population health and certainly data, there were a couple of things that emerged from the report for me that I would share, particularly from the FQHC perspective. In one instance, they talked about really the switching of private physicians and new graduates kind of wanting to be in an employed state. And to me, that just talks about the significant need that we have for workforce throughout nonprofit, for-profit hospital systems, clinic systems, and the like, and how that specific issue is going to rear its head over the next several years. We all know that that's a conversation that's happening all across the nation. We at San Ysidro started our internal medicine residency that was accredited. Our students started their very first year, July 1 of 2020 in COVID. So that should be a good story for them to tell. But we also know that that's a long-term solution, right? And so as our population continues to grow, as the seniors continue to have significant needs, how will we address those workforce shortages? And my colleagues were talking about the way we collaborate as a health system in the community, and I completely agree. But I think workforce is one of those areas where we're good co-opetition, right? And so both the health systems and the clinics who are not only trying to attract the best physicians, but also RNs and LVNs and MAs. And one of the things I think we've learned, particular to this in healthcare, is that healthcare tended to be a good payer relative to other industries and what they were paying. So changes in minimum wages and increases in wages, while we do think that's a good thing because folks shouldn't live in poverty, I think it's going to have a significant impact on healthcare systems who, in order to keep that type of ratio between being a good paying job for those services, is going to really hit the bottom line. So that's number one. Specifically in this report, I was real interested in the Medi-Cal reprocurement system. For us in San Diego, in our geographic managed care, we are hearing from Caroline that we think there'll be fewer than the 7 that there are. But we're really interested in some parity across all the 50 plus counties of California in what the responsibilities of these health plans are to their members, specific to things like social determinants of health and the impacts of CalAIM are going to have on that system and what it is that they're doing. But particular to San Diego, that has a rather trifurcated system between drug Medi-Cal, the Medi-Cal program, and behavioral health along the continuum. It will be really interesting to see how those responsibilities are fleshed out and kind of who does what as we're thinking about that moving forward. I will just close with my colleague just talked about Anil, COVID, right? And we're all COVID fatigued. But there have been some things I think that we have learned, especially knowing that San Ysidro Health provides care to over 110,000 folks a year, many in the South Bay of San Diego County. And so when you talk about a disparate impact of COVID, transmission, cases, mortality, we saw it every day. Our chief medical officer in external affairs just had an op-ed piece published a couple of weeks ago, just encouraging people to remember that we saw their faces. You heard the stories, we saw their faces. So as we're coming out and hopefully turning the corner on COVID, I'm really proud of the work that community health centers have been able to do with testing. San Ysidro tested over 16,000, with getting the vaccine out to folks in a quick way based on the prioritization by the Biden administration to do so. And just as a point of personal preference, I would share with you, my mother was vaccinated by a community health center based on this program, so I'm super proud of that. But as we're thinking about different ways that we are going to cooperate and collaborate and frankly compete with each other in the San Diego market, I really wish we'd be talking about ways to impact workforce. Thank you. Kristen?
Vernita, thank you so much. Really great job. There are so many issues here that I'm really excited to dig in on. And at this point, fortunately, we have 15 or 20 minutes here for some Q&A with the entire panel. So I'd invite everyone to turn their cameras on and unmute themselves. And as a reminder to our audience, please feel free to put any questions you have for any of our panelists into the Q&A box, and we'll do our best to get to just as many as we can. I do want to get started, though. Anne, can you kick things off with our first question for the panel?
Sure. The first question is, how do you see telehealth moving forward in a post-pandemic world?
That is a great question. I think everyone probably has a perspective on that. Anil, I'll give you the honors. I know you had touched on that briefly, but I would like to circle around to everyone. Do you have a perspective to start us, though, Anil?
I do. I think it's funny. When I went to look back at when telehealth started, it actually it's almost half a century ago. It was on the front of a cover of a news journal that had this really fancy idea of telehealth. And I thought, gosh, it only took like 70 years to get to where we got to today. So I think it really depends. I think the providers have engaged in it and supported. I think patients definitely find a use for it. I think it really depends on what the payers, San Diego, you have jets always. It really depends on what the payers and what CMS does in terms of embracing reimbursement. And then I think the other part we have to do is we cannot look at it as sort of as a transaction. It really has to be, we have to digitize the patient journey as opposed to look at it transactionally. So I think to the extent we can put it into the workflow of a patient journey, and we can make sure it has reimbursement, I think it's here to stay. If we don't focus on either of those two, this could be, unfortunately, it could become a flavor of the month. But I'm betting on the former more than the latter.
Appreciate that. Vernita, I hate to put you on the spot. Do you have a perspective on how the experience with telehealth in the clinics has gone so far and where things are headed?
Yeah, thanks, Christoph. We anticipate that, one, telehealth will be here to stay for a number of reasons. I believe patients will mandate it. At some point, it will be the voice of the patient that makes sure that telehealth exists. And in our experience, we're currently still about 70-30, so 70% in person, 30% telehealth. But for a long time, that was flip-flopped. Now, it's not a panacea. Certainly, we've learned with our patient population, there is a significant digital divide. The granular differences between telehealth that's audio only or used by a smartphone, which frankly our patients don't care a bit about, but the payers do. I think that level of distinction will continue to rear its head in how that happens. But I certainly believe telehealth will be here to stay in some fashion as it's reasonable. Right? It doesn't work for everything, and we shouldn't put that expectation in people's minds, but it has its place.
Appreciate that. Luke, do you have any perspective on the use of telehealth for behavioral health services and where that's headed in a post-pandemic world?
Yeah, sure. Thank you. To just sort of pick up on one of Anil's notes, it's to invoke a Stephen Jay Gould concept. I think we've seen a moment of really punctuated equilibrium in the evolution of telehealth, and we've been talking about it also for years in the behavioral health space. And it's been, of course, a topic of great conversation there, partly because of how medical emergency departments are generally resourced and the frequent needs for behavioral health in settings like that and utility of telehealth. We have had in our specialty care system, in our outpatient specialty care system in San Diego County, a full transition into telehealth. Actually, just to the Board of Supervisors yesterday, presented a slide that kind of color codes face-to-face versus telehealth and telephonic contact. And we are, kind of massively in telehealth and telephonic care, both with substance use disorder care and with mental health care. One of the things I called everyone's attention to is that in the one of the charts that I showed, you can see with the most recent massive pandemic surge in December and January, a quite sudden and very dramatic downtick in face-to-face contact in that moment. What we also saw, however, was a maintenance of total service volume, an almost immediate shift into telehealth among our providers. So there's virtually zero interruption as there were sort of many more significant constraints kind of with respect to face-to-face care. There was just an immediate seamless transition into that work and presumably better care continuity. I think some of the points that Vernon is raising are really important. We've really scrutinized among our patient populations which may be having greater challenges in the context of this shift. And one kind of surprising finding we've had is that the cohort, the sort of demographic cohort that has had the most difficulty remaining connected to care in these modalities has been adolescents. Now, I think we would tend to think that adolescents would have the easiest time because they do everything with a device. I have a 13-year-old. I will say the one thing he doesn't like to do with a device is talk. He will play games, he will text, he will watch stuff, does not do a lot of talking. That is, of course, very anecdotal, but it may be a window into some of what we see. And I think we need to learn how to be nuanced about where it fits into a body of work, again, to invoke Anil, that is relational and not transactional. It's got to be really, really a strong emphasis on that. Thank you.
Certainly appreciate the perspective and the anecdote there. Certainly resonates, I think, with a lot of folks on the call. Parag, I want to give you the last word on this. From your perspective at UCSD, how has the experience been with this transition to telehealth, and where do you see things going?
Yeah, so I think, we have the similar experience as others on the panel. UC San Diego or even the other UC campuses have seen a similar trend and uptick in telehealth, and now, somewhere 70% in person or 30% telehealth type of thing. But again, I think, it depends, like Luke has said, it's nuanced. We have to see certain complex illnesses, specialty care has to be done in person. Seniors especially struggle during telehealth, that was a big issue for us. But I think what the other area which I want to address is telehealth is, not just a video modality, but also we are going to take a step forward with digital health in looking at how we monitor chronic diseases. And we can use telehealth, remote patient monitoring, all this under the umbrella of telehealth or digital health to really better manage our chronic diseases in the coming. So I think that we have made that shift, and I think it will continue. That's what we see.
That's great. Well, I know we have a lot of questions coming in. Anne, can you give us the next one?
So the next one is, what are the major racial health inequities in the San Diego market? And how are major healthcare players focused on achieving greater health equity?
Wow, that is a fantastic question. And Anil, I'm putting you on the spot first. You briefly touched on this in some of your remarks. Do you want to take a first crack at that one? But I do want to come around to everyone on this one too.
Yeah, and I think I mentioned in my remarks, I think, that was probably the part in the report that struck me the most. I mean, we're living in a very, very different time. And I'll tell you one thing I'll sort of back up and answer the question, but one of the things I'll tell you, what we're doing at Scripps Health, and I'm sure every organization is doing, is looking at our own approach to diversity, equity, inclusion, and belonging. I think it's important that we, look at it internally as our workforce and also externally. And I think, there's a comment made by someone said, usually the idea that you haven't heard is the voice that's not in the room. And how do we bring all the voices to the table to help us understand where the inequities are and where we need to focus our attention? So, the reports like this gives us an idea of where we need to focus. And, we are in all the diverse areas of San Diego. But I don't think there's a single answer that, we are going to do X to help improve this. This is going to be a series of work, starting first and foremost is going back and working with all of our employees and our staff to understand the diversity that exists out there.
Appreciate that perspective. Parag, I want to go to you next. Do you have a perspective from UCSD on some of the major health inequities that you're seeing within the community, and what are some of the steps that UCSD is taking to meet the moment?
Christoph, this is a pretty good question, and I think it deserves a big session on its own because there's so much work here. But I think, yes, UC San Diego Health is really committed to addressing health equity, not only in its patient care services, but also on how the people who are leading the organization, or how we're looking at even medical school and, the whole thing, So, but I think to give you, yes, there has been, because of pandemic, there was things which we saw very evident. We saw blood pressure rates decline, we saw diabetes rate decline, we saw vaccine inequity. So we saw, we have been using a lot of analytics, and we are also looking at healthy place index type of things to really identify the geographical zones and regions where we need to be present or make those necessary outreach to partner with things. Like UC San Diego Health is partnering with Luke and behavioral health to really meet this, meet that critical need in the community. We have done the vaccine equity project, going into homes, not only homes, but also in the communities to vaccinate. But I think there's so much work to be done in this space, and we can go on, but I'll pass on to the other panelists for now. But
yeah, appreciate that, and certainly want to get to everyone. Vernita, do you have some perspective from the clinics on key racial health equity needs and initiatives within the region?
Well, I think, of course, they all go back to the social drivers of health, right? And so poverty, lack of education, lack of access to care. I can draw you a line between so many of the inequities that we're dealing with that are specific to our patient population, primarily because we do serve those at or below 200% of poverty. Just for your audience, for a family of four, that's about $44,000 before you bought gas or rent or did anything. But I think the testing and vaccine inequities are the most relevant for the time period that we're in, right? And we've heard a lot about that. But in Caroline's report, she shared with you, African Americans, I think, were 4 or 5% of San Diego's population. But I would encourage you to check and see what the death rates for African Americans were in San Diego County for COVID, and I can guarantee you they're worse than that. So I think the numbers speak for themselves, but it has everything to do with all those things that lead up to when something finally hits. And there's one thing that I wanted to share about that issue that I think people speak a lot about, and it's somewhat misrepresented, and that's the multi-generational housing. And so to suggest that there aren't very wealthy families that have both parents and kids in the same house, and that alone is the situation that's causing, more transmission of disease or all of these problems. What we're finding is if you have multi-generations in a home that's 3,000 square feet, you can get away from each other. You don't have to work and be in close proximity to each other. You have the opportunity maybe to work from home. It's not everybody getting up every day and going out into that community to work. So I think as much as it is symptomatic of what's happening today, we're seeing the symptoms of all of those social drivers of health that really drive health inequity and health disparities among our entire population.
Appreciate that perspective. And Luke, I do want to bring you in. We are kind of running out of time here, but can you talk a little bit about, your perspective on major racial health inequities in access to or provision of behavioral health care in San Diego?
There's huge space for doing this kind of work better in behavioral health. Behavioral health is primarily still a kind of crisis responsive area of work. It's lagged behind the rest of healthcare with respect to how it has kind of, shifted to a chronic illness model. That's something that we're very explicit about down here in San Diego. We talk very explicitly about shifting from a crisis to a continuous or chronic care model. And a lot of what that, kind of what current state means is that, or reflects, is that we haven't known what real risk is across the community. We've just been responding to like emergent demand. So the big task for us is seeing where there is risk, seeing where there is vulnerability when it isn't necessarily showing up at an emergency department or in a hospital bed. So among other stuff that we're doing with UCSD, we've actually we're just launching the development of something that we're calling the Behavioral Health Equity Index, which will be a tool that will have into it flowing various sources of quantitative data, including American Community Survey data from the census, but then also community survey data, healthcare utilization data, and then community-based participatory research data, so that we understand in ways that we can't, so that we can really understand epidemiologically what's going on across this community with respect to behavioral health, because we have not had a view onto it. And then we can start making the massive investments that the county is well situated to make, frankly, to work upstream in behavioral health. We can start to do that work meaningfully and in response to disproportionate need.
Really appreciate that perspective, and we are absolutely running out of time, guys. But I can't help but ask this sort of last question, and appreciate the quick thoughts on it from each of you. When Caroline and team come back and write this report in 4 or 5 years, what do you think the biggest change will be? What will have happened within the San Diego market that's most pronounced in 4 or 5 years? Parag, we'll go to you first. Do you have just quick thoughts on that?
I would have aged 5 years by then, that's for sure. But I think, I think the moment in population health has begun here, and I think we're going to see a bigger. We're going to see a growth in this. We're going to see more partnership with health plans, payers, and really trying to address not only the needs of our community, but also address the health equities. I think San Diego, when you look at statewide data, San Diego is leading the way in many ways. And I think we'll continue on that journey and be able to provide really value-based care to our members in an equitable manner. So yeah, I do think there'll be much more success and progress here.
Anil, 20 or 30 seconds, predict the future for us 4 or 5 years from now. What changed?
Yeah, great. I like that, because in 5 years I could be proven wrong. But I would say digital. We are going to see an acceleration of the digital age, because it's happening already, but this year has been a good jumping point for that. So I think we'll see more ambulatory care and more digital care, and all these devices we're wearing will start to, that idea will come to fruition. That will be how we start to see our healthcare managed.
Vernita, 20 seconds. What's different in 4 or 5 years?
I think your PACE programs and focus on senior programs will be significantly bigger as our population ages. And I think our payers will start understanding the importance of case managers and ancillary support staff to provide good quality care. That's just a hope, but I'm sticking to it.
Appreciate it. Luke, you get the last word. 15 seconds. What's different in 4 years?
The physical infrastructure supporting behavioral health across the continuum will be massively built out. And then if we can push it to 6 or 7 years, maybe good news from a federal waiver too.
Appreciate that. Well, all our time is up, guys. I could talk to you all afternoon, but just really appreciate everyone taking the time. Thank you, Caroline, for a great report. A reminder to our audience, all the information, the report, the webinar, recording the webinar will be up on our website. And please do fill out that evaluation. That'll pop up. So with that, thank you to our panelists. Thank you, Karen, Angie, Scott, everyone behind the scenes. And thank you into the audience. Thank you in the audience for joining us. We'll see you next time. Bye-bye.